Audio.
Let me clarify more.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف خلق الله أجمعين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Today inshallah I'm going to talk about or to discuss chest examinations. Put in your mind that two examiners observing you while you are doing the chest or any clinical stations because of 5 skills. This 5 skills examination technique, welfare, and picking up the finding and differential diagnosis and plan of management. Nobody is going to ask you what is your diagnosis, and they will ask you and they will assess you based on the skills. And the most common cause of failure of failing this basis or any exam is finding in clinical station, while in talkative station is concern and communication skills. People in this basis, they fail this exam because of identify finding in clinical stations and because of concern or communication skills in talkative stations. That is why in clinical stations, please don't link your heart to the steps of examination techniques. Train yourself. When you come to the exam, you will be free only for picking up the finding. Then tell the examiner this is the finding, and the examiner will ask you what is the differential diagnosis of this finding and what would you like to do further. Investigations and plan of management. Chest examinations. You will be sitting like this, 2 examiners, they will open the door, then you will greet them, then you will come to the patient. Don't go to the patients. Wash your hands first and go to the wall, read the instruction inside the wall, examine the chest. This patient complaining of repeated chest infections, examine his chest, that means I am dealing with bronchiectasis. Most likely. Hello, good morning. My name is Dr. Adam. I would like to examine you. During my examination, if you feel any pain or discomfort, let me know. Take 2 steps away to take general observation for the patient. If you did not take 2 steps away, they might minus you. They will write in the feedback candidate, he did not take general book. While you are taking 2 steps away, say for him, during my examination, if you feel any pain or discomfort, let me know. Then I will examine from here to look for any oxygen cylinder or any sputum both beside the patient. Then I will start by the hands. Can I have a look to your hands, please? Look for number 1, clubbing. Do like that. Number 2, for any deformities is there. Number 3, separate these fingers together like this to look for any nicotine stain. Then after that, can I have a look to your palm of your hands to look for any cyanosis or any palmar erythema. Then after that, do like that. Then I will sit with him like this to look for any flapping tremor. Then I will put his hands down. Then I will put my 2 fingers here to look for the respiratory rate. While I'm calculating the respiratory rate, my hands should be on the pulse. Then, after calculating the respiratory rate within around 15 seconds, then I will come to start my journey from above down. Above the eye, looking for jaundice. Below the eye for pallor. Within the mouth for cyanosis. And below the mouth to the neck for any raised JVB. Within the chest to have 3 look. Left laterally, mid in the middle, then right laterally to pick out any scar. That is why, and if there is any scar, move your index finger on the scar like this patient. Yes, I will look here, here to look for any scar. If I got a scar, move your index finger beside the scar to tell the examiner I saw the scar. Even if you forget it, examiner he saw you move your index finger to the on the scar. Then you will come to the end of the bed. In the end of the bed, 3 steps. Number 1, or 2 steps. You will sit like that. Your head should be within the same level of the chest of the patient. Then I will ask him, take deep breath, نفس عميق. Again, to identify any asymmetrical of the chest. The second step, can I press on your limbs, please? If you feel any pain, let me know. Okay? Press on beating edema and look to his face. Then after that, check the beating edema. Don't press like this. Press wide to in his face. Then after that, lift your hand to check for any beating edema. Then lastly, give me your diagnosis. Can you give me a cough, please? كحة. Again. This cough now is productive cough. That means I am dealing most likely with something called bronchitis. If he gave me dry cough, that means most likely I'm dealing with pulmonary fibrosis. Again, the journey from above down. As soon as you finish the pulse from here, start your journey above the eyes. Please, can I have a look? Join this. Then below the eyes to look for the ballon. Then within the mouth, raise your tongue up. Then take your torch to look below his tongue. In the chest, I know one candidate, he raised the tongue like this. But he said, he opened the mouth of the patient like this. But he did not raise the tongue to check for, they wrote it for him in the feedback candidate, he didn't check cyanosis in patient with respiratory examination. That is why, can you open your mouth, raise your tongue, take the torch and put it below the tongue. Then after that I will come to the neck. Can you have a look there, please, to check for any raised JVB. Then below the neck to the chest to have a look, lateral, medial, and right lateral. Then you will come to the end of the bed to sit down to check nafas. Then after that, كحة. I know that is productive cough. Then I will medial malleolus. Above it, I will press for beating edema like this. Do you have any pain, please? No. Thank you. Can I press? Yes. Then I have a look to the beating edema. Then I will come to the chest. While I come into the chest, I have to warm my hands first. Warm my hands first. If you go to YouTube's or any different books, different examiners and different consultants, and they have different methods or different technique of examination. Some people start the chest anteriorly and some start it posteriorly. Take for yourself one frame of examinations. And CNS, there is many ways for examinations. Abdomen, there is many techniques. Take only one technique, print it in your brain and train yourself on it. Personally, if the patient having any rheumatoid deformities or any evidence of systemic sclerosis, I will start the chest posteriorly. Better to start posteriorly because all the things are put on the back. If no, I will start anterior. Then I will start by chaba. I will warm my hands. This chaba in the form of chest examination, chest expansion, then percussion mode, then auscultation. That means any chest any examinations, you have to, in the chest, you have to link your heart, link your brain, link your thinkings to these three items: chest examination, chest expansion, percussion on auscultations. Because examiners behind you, when you finish that case, they will say to you, present your finding. You will present your finding based on this chest expansion, percussion and auscultations. The findings are here, auscultatory findings. Then I will start by chest expansion. I will warm my hands, and you have to warm your hands. If your hand is still cold, and the patient, he said, ah, here, this is welfare. Unlikely you will pass this exam easy. Take care, warm your hands. Maybe if you feel your hands is still cold, tell to the examiner, by excuse me, boss, by nature my hand is cold. By nature my hand is cold. Chest expansion divided into three areas: above the nipple, within the nipple, below the nipple. Above the nipple like this, nafas. Within the nipple like this, nafas. Below the nipple like this, nafas. This is my personal technique. There are different techniques. Then after doing this, some people say doing like this, no problem. Then after doing this, immediately put your hands into apex to identify where is the apex, on the right or in the left. After finishing this, immediately put your two fingers into second palpable second heart sounds in the pulmonary area. If the three steps in palpation of the chest, three steps. Number one, above the nipple, nafas. Within the nipple, nafas. Below the nipple, like this, stretching the skin like this, again, nafas. Then after that, apex. Then after that, if you did not get it, tilt the patient to the left sides, enough, I know it. Then after that, above that, for palpable second heart sounds. I finish palpation. I will come to this chest expansion finish. I will come to the percussion notes. Percussion notes like this: above the clavicle, then supramammary, 3 intercostal space or 2 intercostal space, mammary 1 intercostal space, inframammary 1 intercostal space. Again, supraclavicular like this. Can you look there, please? Again here. This is supraclavicular. Then supramammary, 2 intercostal space, 2 lines, mid clavicular line and mid axillary line. Again, mid clavicular line and mid axillary line. In the mid clavicular line, I will start supraclavicular, then supramammary, 2 or 3 intercostal space, 1, 2 is enough. Mammary, 1 intercostal space, inframammary, 1 intercostal space, and go lateral. Then I will come to the axillary lines. Here, again, can you do like that? Yes. I finish my percussion notes. Percussion notes in chest divided into 2 lines: mid clavicular line and mid axillary line. Mid clavicular line above the clavicle 1, then supramammary 2 intercostal space, mammary 1 intercostal space, inframammary 1 intercostal space but lateral. Then I will go to the axillary line, 3 intercostal space. 1, 1, 1, 1, 1, 1. Here, I notice that this gentleman has left thoracotomy scar. And I don't know whether with which types of lobectomy I'm dealing with. Because from the end of the bed, this patient definitely not pneumonectomy. Why? Because from the end of the bed, the chest is not doing like that. If from the end of the chest is doing like that, yeah, if the patient having pneumonectomy, you will get the chest most likely like that. all the lungs is removed. But here it is not like that. Most likely I'm dealing with lobectomy. Here, finish your percussion nose. I will start. Imagine that the left lung. Focus with me, please. Here, focus with me. Imagine that the lower lobes of the lungs is removed. Imagine that. When I percuss from above, here in this area there is lung. In this area there is no lung. When I percuss from above here, it will be resonant, resonant, resonant because there is lung. When I go down below the scar, it will become dull. It will become dull. That means there is lower lobectomy. That means if you meet someone beside you having lobectomy, you can say for him, and you would like to bring the diagnosis, you can say for him, can you do like that, please? Can you do like that? And start to percuss from above down only. Imagine that the upper or the lower lobe is removed. This area where there is no lung, it will be dull. How you will identify it? Percuss from above. The area, the above area will be what? Resonant. I will start, resonant, resonant, resonant. When I come down, it will become dull. That means the lower part of the lungs is removed. That is why it is dull. Here, what I need from you is do your percussion notes as usual. Like, as I said to you, the axillary line, 1, 2, 3, 4. Yes, like this. You finish the 3 area by comparison, but there is no pneumoctomy or lobectomy scar. There is thyroidectomy, there is left thoracotomy scar. Start, complete your percussion notes. Can I know your diagnosis, please? 1, resonant, resonant, resonant. It become dull. Thank you. You have lower lobectomy because before I finish my exam. Then I will come to the auscultations. To summarize to you again, percussion nose, mid-clavicular line and mid-axillary line. Mid-clavicular line, supraclavicular, and then supramammary 2 space, mammary 1 space, inframammary 1 space laterally. Then after that, by comparison in the axillary line here and here, here and here, here and here, 3 intercostals. If there is lateral thoracotomy scar, start from above down. Yani after finishing percussion, not do this. If the patient having upper lobectomy as example, it will become dull, dull, dull. When I come down, it will become resonant. Then bye-bye percussion notes. I will come to the auscultation. Auscultation, you are going to auscultate the following. The same area of percussion notes. The same area where you percuss before, you are going to put your stethoscope for 2 sensations. Number 2 auscultatory findings. Number 1, higher entry and abnormal sounds like wheeze and crackles. Number 2, for vocal resonance. I will start number 1. Where I percuss above the clavicle. Nafas? Nafas? Yes. By what? By the bill. Then I will shift it to the diaphragm. I percuss supramammary 2. Here, nafas, 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 nafas. Then mammary, also nafas, nafas. Then inframammary, here, nafas, nafas. Then axillary, 1, 1, 1, 1, 1, 1. Same area where you percuss, you are going to put your stethoscope. But I saw, after finishing my auscultation, I saw that this gentleman has left thoracotomy scar. I would like to bring the diagnosis. Can I do it? Yes. Take deep breath. Take deep breath. Here there is lung. Imagine that there is lobectomy lower. I will start here. Yeah, the lower part is removed. In this area, the air entry will be reduced. That is why when I ask him take deep breath, there is air entry, yes, there is air entry, yes, there is air entry. When I go down where there is no lung, the breath sounds will be diminished. That is why I say to him, thank you. Again, I confirm that you have lower lobectomy. That is why if someone beside you, anywhere, you would like to identify whether this is lower lobectomy or upper lobectomy, ask him to do like that, please. And auscultate from above. Air, air, air. If there is lower lobectomy in this area, there is no air in there. If there is pneumonectomy from the present, absent air entering all the side of the side of the chest. Then I will come to the next step, to the vocal resonance. Again, the same area where you put your stethoscope, you are going to 99.
99.
99. Okay. Then I will do same, 99. Okay, no problem. I will do it. 99, 99, 99. Supramammary 2. 99, 99 mammary. Then 99, 99 inframammary. Then I will come to the axillary line. 99, 99, 99, 99, 99, 99. Then I saw he has got lateral thoracotomy scar. If you have a doubt, again do it. 99, 99, 99. If there is lower lobectomy, when I come here, it will become 99, 99. يبقى the vocal resonance will be reduced down. That means really this gentleman has left lower lobectomy. Here I finish my anterior part. طيب, imagine that you got curriculums. You got a wheeze, link that into your pocket. Put it in your pocket. Because wallahi, if you miss the wheeze, or you miss your auscultatory finding, the examiner, he will ask you, present your finding. What else? He will say to you, what else? The second part, what else? The third one, he will say to you, proceed. Why? If the examiner, he said to you, what else? Put in your mind that you are drinking poison. Or put in your mind that there is big mistake. Or there is something important. Your tongue. You know it and you saw it. But your tongue is not... You get difficulty to mention it. That is why link your heart to the finding. You will pass. Don't link your heart to the steps of examinations. And don't take the patient in clinical as one piece. Cut the patient into pieces. This piece is in the form of skills, you will pass. Don't take the patient as one unit. It will be very difficult for you. Finish your examinations, pick your finding, tell the examiner, this is my finding. The differential diagnosis, he will say to you, what is the differential, what is the plan of management? Finish the case. I'm going to the, if you got curricles as examples, here, ask the patient to take deep breaths. Digest the nature of the curricle first in your brain. Nafas, again, nafas, I guess this is, yes, this is inspiratory, course, inspiratory, I digest it. Now, can you have a look there, please? Can you have a look there? Now, can you give me cough, kuha? Then, now take deep breaths again. I will know whether this curricles change it. If it is partially changed, that means this is bronchiectasis for differential diagnosis. Differential diagnosis will be changed, plan of management will be changed, everything will be changed. Why? Because the nature of the curricle has been changed. If the curricle is not changed, that means I am dealing with pulmonary fibrosis. The plan of management will be changed, differential diagnosis will be changed. If it is disappears, this is secretions. Either this curriculum partially changed, this is bronchiectasis, not changed, this is pulmonary fibrosis, or disappear, might be secretion, consolidation of something else. Now, sometimes the examiners, they are going to stay on this side, like this, and definitely like this, observing you. Here, the patients, you will ask the patient now, can you give me a cough? He will not cough on you. You will say to him, can you have a look there? He will cough on this both examiners standing here. Tell the examiners, excuse me, boss. I would like, can you take care for yourself, please? I'm going to ask this patient to give me a cough. This is impression, good impressions. One of the candidates attended with me before I said to him, like, he said that a consultant, he met him outside the hospital. He said, as you take care for us, before we did good for you. We take care for you also. That is why, here I finish my anterior part of my chest. Then I will come to the posterior part of my chest. Can you sit down, please? Then I'm going to examine the back of the chest. The patient, he will do for me like that. I'm going to examine the back. The patient, he will say to me, no, trachea. I'm going back. He will say to me, don't go to the back. The barrier between the anterior part and the posterior part is trachea. For this trachea, 3 steps. The first step to identify whether this trachea is deviated or not deviated. The second step is to identify the signs of hyperinflation in the form of reduced cricosternal notch distance or tracheal descent with inspiration, what we call in medicine tracheal type. Can you focus please here at the here also? Yes. Now can you ارفع راسك لفوق شوية? Then I will for the first step tracheal deviation. ارفع راسك لفوق شوية. Then I will come here to see. First, to have a look about the trachea. From inspection, this trachea looks likely deviated to this side. Then I will bring my finger like that, from the sternocleidomastoid like that down, and I will percuss here. Then also here. Can you sit here to make it? Don't bring only focus here in the middle. Huh? Can you raise? From inspection, I have a look. Then I will come from sternocleidomastoid to check for space between the lower end of the tendon of the sternocleidomastoid and the trachea here, and also here. You will get that the space here is very narrow, or if it is deviated to this side, it will be what? Less. If it is deviated to this side, this finger will be less. The space will be here will be less. Then I will come to the second step, which is cricosternal notch distance. This is the thyroid cartilage here, below it immediately the cricoid cartilage, the sternal notch. You will check here, you will get the cricosternal notch distance around 3 fingers. This is normal, 3 fingers and above. Imagine that this patient having hyperinflation, the chest is hyperinflated, full of air. This distance will become around 2 fingers. Or become around 1 finger. That means this is signs indicating that this chest is hyperinflated. I will come to the third step, which is tracheal descent with inspiration. If this patient having hyperinflations like pneumothorax, when I ask, I will do like that, take deep breathing, nafas, I will feel the tracheal descent movement with inspirations. That means it's going to touch me in my finger, indicating that this is signs of hyperinflation. I mean that if someone having hyperinflation like COPD, if you put your finger like this, take deep breathing. Now if you put your finger like this to check the tracheal movement, no one of you having feeling, no one will feel the tracheal descent. But if the patient having hyperinflation and you put your finger like this, you will feel the movement of the trachea in your index finger, what we call in medicine tracheal descent movement or tracheal type. That is why in trachea 3 steps. Number 1, deviation like this. Number 2, cricosternal notch distance like this. Cricosternal notch distance, don't ask him to take deep breath, but to put it like this. If hyperinflated, the diaphragm is pushing this lungs down, or the lungs is pushing the diaphragm and the lungs is hyperinflated, you will get it like this, 2 or 1 fingers. Then the last one is take deep breath. Tracheal type. Again for the tracheal deviation, number 1, cricosternal notch distance like this. Number 3, take deep breath. 1, 2, 3, take deep breathing. Then I will come to the back, relax. You can sit now. After I finish in the anterior part, I will go to the posterior part. He will push me to not go to the back unless I check the trachea. Then I will come to the back. In the back, I have to do what? Focus with me. I have to do inspection first. If you did not do inspections of the back, they will minus you. I will do my inspection first. If there is again, yes, same scar here. Also, there is 2 small scars here. Okay, thank you. Then I will come to the same steps. Chest expansion, percussion, not auscultation. Chest expansion, I will move my hands above the scapula. within the scapula, below the scapula. I mean suprascapular, interscapular, infrascapular. Above the scapula, نفس. Within the scapula like this, نفس. Below the scapula like this, نفس. To check it. Then I will start, I finished test exercise. I will come to the percussion notes. Percussion notes above the scapula, suprascapular, interscapular, infrascapular. Suprascapular, do like that please. The only position when you are going to do percussion, this is the best area to do the bit to ask the patient to do like that. Suprascapular like this. Don't percuss above on the scapula. Suprascapular. Then interscapular. Interscapular 3 intercostal space. Here and here. Don't percuss again. Can you move to this here? Don't percuss on the, this is the medial borders of the scapula. Percuss on the, in this area, the space here and here. If the examiner saw you percussing above the scapula like this, they will minus you. Forget that you will get 20, they will give you 19. Why? The candidate do percussion notes above, on the scapula. Then interscapular 3 intercostal space. Here, 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 here. Then infrascapular 2 intercostal space, but lateral. Here. Then like that. Is that okay? Then the percussion note in chest above the scapula, interscapular 1, 3 intercostal space, infrascapular 2 intercostal space lateral. This is the scapula, yes, intercostal space. Here, again here, and here. Then after that, okay, thank you. You have to auscultate on the, okay, on the same area where you percuss. I'm going to do 2 maneuver auscultation. I finished the percussion notes. I will come to the auscultations. Then after that, number 1, above the scapula, nafas, 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 nafas. Interscapular 3, okay, nafas, 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 nafas. Infrascapular 2, nafas, 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 lateral. As the same area where you percuss 1, 3, 2. You percuss 1, 3 intercostal space, suprascapular 1 intercostal space, interscapular 3 intercostal space, infrascapular 2 intercostal space laterally. Same area you percuss, you will put your stethoscope. Nafas, 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 like that. I finish the first part of auscultation. I will come to the second part, which is vocal resonance. 99, 99, again here 99, 99, 99, 99, 99, 99, 99, 99. Then after that, I finish this, I will come to the lymph nodes. In the lymph node, I will start by submentally, then submental, mandibular, then 2 anterior auricular and anterior cervical, then 2 posterior auricular, posterior cervical and occipital. Then do like this please. Can you do like this please? Do like this. Then I will come to the supraclavicular. Again, the lymph nodes again, submental, submandibular, then 2 anterior auricular, anterior cervical, then 2 posterior auricular, posterior cervical and occipital. Then do like this, so we can. Then I will come to the supraclavicular. At the end, I will say to him, do you have any pain, please? I would like to press on your back. Do you have any pain? Okay. Press for sacral edema while your eyes is here. Then I will check it. Then I will sit, let the patient lie down, and I have to cover him, and I thank him. Thank you. Okay, this is regarding the examination technique. I finished my examination techniques. I didn't open my mouth I got 8 marks in my book. The first 4 is examination technique. The second 4 is welfare. The patient, he didn't say, this is 4 marks. Then I finish my exam from here. I give my first examiners to the examiners. I will say to the examiners, I will not be in stress from your side, because I know that you are going to ask me FDB, finding, differential diagnosis of the finding, plan of meaning. Usually don't say in the basis or in the Irish exam, don't irritate the examiners by starting no. Many people, they cannot present their finding if they did not start. They have to start by no. On examination of this gentleman, he has no stigmata of chronic liver disease. He has no he has no examiner. He will say to you, stop, present your finding. And if the patient, he said to you, stop, in the basis or any exam, you will get mental block. You don't know from where you are going to start again. And the examiners, you will get mental block in 2 situations in the exam. If the patient, if there is an examiner, he changed his facial expression to you during the exam, you will get mental block. The second mental block, if he said to you, stop, present your finding. If I give you my mark sheet, you will not get negative finding. This no, there is no peripheral stigmata of infective endocarditis, there is no clotting, there is no res JVB, there is no, at the end, you are going to think about the positive finding. This is wrong. And he will say to you, stop, the only things between you and the issue between you and between me and you is positive finding. If you mention it, you will pass. Mention the positive findings randomly than to mention the positive findings well organized. At the end you will miss or you invent finding. That is why don't start by no. Link your heart to the positive finding, you will pass. Wallahi, the most common cause of death in candidates in this basis because of finding in clinical station and in concern in talkative station communications or history or station 5. That is why when I come to the examinations of the chest, on all the chest cases, whether fibrosis or lobectomy or COPD or consolidation or pleural effusion, all of them, with exception of bronchiectasis, all of them, they are sharing one frame of presentation. This Java. If you say to the examiners, excuse me, examiner, can I have a look to your mark sheet in the chest? You will get this. You want to pass or you want to waste your time? You want to pass? Yes, link your heart to the positive finding. Don't say for me any negative finding. What is your finding? Present your finding on this patient. I will not come to this Java unless I start by inspecting finding. Inspecting finding first by using has. On examination of this gentleman, has. Inspecting finding 1, 2, 3. Apart from that, Java. Now I will start. On examination of this gentleman, has. Has what? On examination of this gentleman, has. If there is has, okay. No has hazard, no has inside this patient, no inspecting finding, go immediately to the inside the chest. On examination of this gentleman, has left thoracotomy scar, has 2 small scars below it. I finish it. On examination of the chest, Java. Chest expansion is reduced in the left lower zone. Percussion note is dull in the left lower zone. Auscultation, there is reduced air entry in the left, or there is reduced breath sounds in the left lower zone, plus reduced vocal resonance. My summary, this gentleman has got a feature consistent with left lower lobectomy for differential diagnosis. Again, they have 2 options. Patient with pulmonary fibrosis, patient with COPD, patient with any, start following this. If you got it, say. If you did not get it, good, I could not appreciate it. But on examination of this gentleman, has. In the left lower zone, on examination of this gentleman, has, and in the has left thoracotomy scar. Below this scar, there is small 2 scars. And in the left lower zone, examiner, he will say to you, what is wrong in the left lower zone? Give us yes, yes, yes. I will say to him, in the left lower zone, chest expansion is reduced, percussion note is dull, auscultation, there is reduced or diminished breath sounds, and there is reduced vocal resonance. My summary, this gentleman has got a feature consistent with left lower lobectomy for differential diagnosis. Then examiner here, he will ask you, okay, before examiners, if you, this lobectomy is very easy in the exam to pick it out. Just start from above down, percussion or auscultation from above down to pick it. As soon as you pick it, cook it, cook. Definitely this chest expansion is reduced in this area, where there is no air entry, where there is percussion note is dull. Definitely, this is on examination, this gentleman has left thoracotomy scar. Below this there is two small scars. Focus here. Because of these two small scars in last day, no need to mention the centers. These two small scars, if you did not mention it, because candidates, they didn't mention it, they minus them. They will minus you. This because of drainage. These two small scars because of drainage. On examination of this gentleman, left thoracotomy scar, below it there is small two scar. In the left lower zone, chest expansion reduced, percussion note is dull, auscultation there is diminished air entry or diminished breath sounds plus reduced vocal resonance, a case of left lower lobectomy for differential diagnosis. Imagine that it is upper lobectomy. Yani I percuss here, it become dull. When I go down, it become resonance. I put my stethoscope, there is no air entry, there is no air entry. When I come down, it will become what? There is air entry. That means the upper part is removed. Present your finding. Has an inza. This gentleman has left thoracotomy scar, below it there is two small scars. Has trachea deviated to the left side. In the left upper zone of the chest, chest expansion is reduced, percussion note is dull, auscultation there is reduced air entry or reduced breath sounds plus reduced vocal resonance. A case of left upper lobectomy for differential diagnosis. Examiner, he will ask, what is the differential diagnosis of left thoracotomy scar? Number one could be lobectomy. What else could be pneumonectomy? What else could be single lung transplantation? What else could be lung reduction surgery? Again, what is the differential diagnosis? Differential diagnosis of left thoracotomy scar, lobectomy, pneumonectomy, single lung transplantation, or lung reduction surgery. Last thing you can say could be trauma. Shift yourself. What is the differential diagnosis of the causes of lobectomy in these patients? In this patient, imagine that I hear crackles. During my examination, imagine that I hear crackles here or there with wheeze. That means I have to know what is the nature of these crackles. Change it or not change it. I get it changed. That means there is two pathology. Lobectomy plus bronchiectasis. Presented like this. This gentleman has left thoracotomy scar. Below it there is two small scars. In the left lower zone, there is chest expansion is reduced, percussion not dull, auscultation, there is reduced air entry with vocal resonance in this left lower zone. Apart from that, go for the second pathology. Apart from that, also by auscultation there is coarse inspiratory crackles, partially changed with cough, distributed mainly in the right, in the left, in the upper zone of the chest with wheeze, with scattered wheeze. My summary, this gentleman has left lower lobectomy for differential diagnosis. If the examiner, he will ask, what is the differential diagnosis in this patient? I will say to him, in view of this coarse crackles partially changed with cough, the top of my differential diagnosis is bronchiectasis. So that if you got mixed lesions in the chest, bronchiectasis, fibrosis, the time is not enough for that. Cut it, divide it alone, anyone alone. Then take them together. What is the differential diagnosis of lobectomy in this patient? Number one, lung bronchiectasis. What else? Lung cancer. What else? Lung abscess. What else? And lung bronchiectasis. lung cancer, lung abscess, and even lung adenoma or lung nodule, lung adenoma with bleeding or lung nodule with unknown origin. What investigation you would like to carry out for this patient? To confirm my diagnosis after basic investigation, CBC, RFT, LFT, electrolytes, I would like to do for this patient chest, high resolution CT scan. What test, other tests you would like to do? Pulmonary function test. What do you suspect? Restrictive lung disease. What is the treatment? The treatment is non-pharmacological and pharmacological. Non-pharmacological education counseling about his disease, stop smoking, vaccination as appropriate. He will ask you what types of vaccine. Say for him, pneumococcal hemophilus influenza virus. Pneumococcal hemophilus influenza virus. Nahi. Pneumococcal hemophilus influenza virus and pulmonary rehabilitation program. Pharmacological treatment, treatment of any exacerbations and regular follow-up in our outpatient clinic. Thank you and see you for another session inshallah.